This conference will now be recorded.
Okay, so all right, sorry, I'm trying to, okay. I think we should be good now. Okay, guys, so we are on week 14 today. Today's going to be a little bit of a shorter lesson. So we are going to go just do questions today. I know typically we cover topics. Typically we cover different types of topics, but today we're going to be just going over some questions. As you guys know, I sent out a big email last week that we're still going through our EPIC transition. So, you know, I'm still learning, still learning a lot about EPIC in general. So it's just a big learning process. Okay, so first things first, the call for speakers. So if you guys don't know, APIC 2023 is going to actually be in Orlando. So Orlando, Florida is where the conference is going to be next year from June 26th to the 28th. And they are accepting call for speakers. So if you go on their call for speakers website, you'll be able to read about what their guidelines are for this upcoming year's submission, and you can try to get some of the work that you've done submitted so you can hopefully be a speaker at APIC in 2023. So I just wanted to get that on everyone's radar because the deadline is coming up very quickly. It's on the 14th. So deadline to submit proposals is August 14th at 11:59 p.m. So now you know. Okay, so we're gonna go through some questions. Somebody put in the chat, where are you putting these recordings? Sure, let me show you. Okay, so if we go to YouTube. Okay. And we type in CIC epidemiologists. You'll see this little channel right here. It's a Bitmoji of, or I don't even know what they're called anymore, but of my friend Danielle Rankin and I, and CIC epidemiologists right here. You can see all of our previous videos, everything I've posted, PowerPoints, different types of things that we've discussed. You can go in there and watch whatever has been posted. So that's where you can find the recordings. Okay, hope that's helpful. All right, so let's do some questions. Now, today's not going to be as long of a lesson as it's usually on Fridays, which is okay. It's mostly because my brain is a little fried after 2 weeks of a new EMR. But hopefully this will give you a good opportunity of practicing some of the knowledge that you already have and going over some of the things that we've already discussed in our previous meetings. Okay, so question number 1. Please select which elements are included in an occupational health program. 1, surveillance. 2, education. 3, immunizations. 4, isolation precautions. And 5, injury prevention and response. So you can go ahead and type your answer into the chat. And I'll give you guys a couple seconds. Okay, my bad. I was talking and I had not unmuted myself. So, okay, got lots of different answers. So I have a couple B's, a couple C's, a couple A's, but it is actually Maria who is correct. Okay, and it's actually gonna be D. So elements, and this is gonna be from chapter 100, occupational health. Elements of an occupational health program include surveillance, education, immunization, and injury prevention and response. So these are the components that APIC wants to make sure we are aware of when it comes to an occupational health program. Okay. All right. I feel like that could be a little bit of a tricky question. I see why we would want to immediately lump in isolation precautions into an occupational health program, but this is the exact definition that they have for us. So you have to remember, you got to go based off your APIC text and your CDC information. Okay, the average risk for transmission of HIV by the exposure type is select all that apply. So this would be like a little check mark, but it could just be like 1, 2, 3, 4. So you would put whichever ones you think are correct. The exposure. All right, let's see what we're dealing with. Okay. Not sure that we've had a lot of responses to this one, but we're basically trying to see the average risk for transmission of HIV by exposure type. Okay, so these three were correct, 0.3 for percutaneous, 0.1 for a mucous membrane, and less than 0.1 for non-intact skin. And again, this is going to be chapter 100, occupational health. So we did cover quite a bit of occupational health. Not this past week because we didn't meet this past week, but the week before that. And remember, one of the things I told you is you're gonna want to make sure that you know your transmission percentages for HIV, for hepatitis B, hepatitis C. Those are very common questions that I feel do come up on the test. So making sure that you know this. So the average risk for transmission of HIV by the exposure type is 0.3% for percutaneous, 0.1% for mucous membrane contact, and less than 0.1% for non-intact skin contact. All right, question 3, this is just a quick true or false. OSHA's bloodborne pathogen standard provides directives for employers to develop an exposure plan that includes providing the hepatitis B vaccine to employees within 21 days of employment. True or false? And you can put your answer in the chat. Okay, so we've got the majority of people are saying it's true, but we do have 2 of our team members that are saying it's false. Juanita and Cheryl are saying, nope, I believe it's false. And they would be correct. Why is this one false? Why is this one false? A lot of the information on it is true, but there's a specific piece that's not true, which is kind of important. So Maria's saying it's not 21 days. Very good. So the OSHA's bloodborne pathogen standard provides directives for employers to develop an exposure plan that includes providing the hepatitis B vaccine to employees within 10 days of employment. Very important thing for you to know, okay? It's the time frame. It is the time frame. All right, question 4. Which of the following are considered to reduce the chance of transmission of Neisseria meningitidis to laboratory personnel? 1, surgical masks. 2, gowns and gloves. 3, a biosafety cabinet. 4, N95 mask and gloves. And 5, immunization. Take some time, read through it, and then go ahead and post your answer in the chat. Okay, we've had quite a couple of answers come through. The C's and the D's are tied, and now the B's are tied. Okay, so everybody's like, it's definitely not A. I don't see any A's, so that's really good. Okay, so when you are looking at this question, right? I'm gonna use my pen situation here. So the things that you have to think about is we're dealing with Neisseria is the first thing. And the second thing that you have to pay attention to is laboratory personnel. Okay, so the lab is a very, very special place, and your lab personnel are very, very special people. They are dealing with all of the shenanigans that the acute care hospitals are sending them, all of the different samples, things sent incorrectly, just they put up with a lot. The lab puts up with a lot. And so it's really important to understand that when you are being specifically asked about lab personnel, that you have to take what their safety recommendations are, right? So if I have a patient out on a unit that I'm ruling out for Neisseria meningitidis, right? You know, young guy comes in, nuchal rigidity, photophobia, whatever, meningismus. I'm ruling him out for Neisseria meningitidis. What isolation am I going to use for that patient? Droplet. Correct. Yeah, that's what our recommendation is. Droplet. Okay. So at minimum, we know that we're gonna be using our surgical masks, right? But that's in the inpatient setting. That is in a unit. That's not in the lab. Okay. So that's what I want to make sure that you pay attention to. Whenever they're pulling in specific populations into your questions, you kind of almost have to switch that hat. And the thing that's difficult personally for me about some of the very specific lab questions is I've only really done lab stuff in school, right? Like I've never worked in like a micro lab. I have visited micro labs, and they're really interesting, but I've never really worked in one. So you have to try to know these things to the best of your ability, whether it's by reading or education or whichever way you can learn the information. So the recommendations is going to be that we wear our surgical masks, our gowns and our gloves, a biosafety cabinet, and immunizations. So let's go over the rationale. So transmission to laboratory workers is also a concern and reinforces the importance of, and this is specifically for Neisseria meningitidis, mask, gowns, and gloves when manipulating secretions or potential aerosols, biosafety cabinet, BS2 precautions for working with cultures of Neisseria meningitidis, and immunization of microbiology laboratory personnel. In 2002, the CDC reported 2 cases of fatal laboratory-associated meningococcal disease that occurred in microbiologists who had handled clinical specimens of N. meningitidis serogroup C. This study identified an additional 14 cases of laboratory-acquired meningococcal disease occurring in the preceding 15 years through a listserv survey. The overall fatality rate in this series was 50%. Okay, so gotta make sure we pay attention to our lab personnel. All right, question 5. The risk of hepatitis B virus seroconversion after a percutaneous injury ranges from blank to blank %, depending on the hepatitis B antigen status of the source person. Okay, so the risk of hepatitis B seroconversion after a percutaneous injury ranges from blank to blank %. Blank to blank %. Go ahead and post your answer in the chat. Okay, so kind of getting a couple of answers to here. B, C, B, C, D, A, all of them. Okay, so all of the answers. Okay, so on the test, when you see a question like this is what I like to call my black and white questions. This is just a very quick question. And let me tell you something, either you know it or you don't. And it's very simple. What you do with these questions is you are going to make your best educated guess and you are going to keep it moving. Do not, by any means, waste time trying to pull this information from the depths of the back of your mind. These are the black and white questions. Another example would be, what is the temperature that Legionella what is the temperature of water that kills Legionella? And it's going to have different numbers. Okay. Personally, I can't tell you right now off the top of my head, but that's an example of the type of questions that they might ask you on the test, and those I call the black and white questions. Either you quickly know it or you don't, so you're going to make your educated guess and you're going to keep it moving. Okay, don't waste your time. This question would not be worth it, because when you waste a lot of time trying to pick an answer or figure something out, that means that you are distributing your time in not the best way. Sorry, that doesn't sound very classy the way I just said it. But what I'm trying to say is you have to pay attention to your time when you're taking this test. It requires a lot of stamina, and it requires a lot of mental stamina specifically, because there are tough questions and there are some questions that are going to need to take up a lot of your brain power. These type of black and white questions where it's just a number or a date or a range or something very specific. It's either you know it or you don't, and you're going to keep it moving. So the correct answer for this is going to be 23 to 62%. The risk of hepatitis B virus seroconversion after a percutaneous injury ranges from 23 to 62% depending on the hepatitis B antigen status of the source person. And that's going to be under chapter 101, which is occupational exposure to bloodborne pathogens. This, however, is not a black and white question. This question does require that you understand immunology. So I hope that you understand that there are some questions that are like this, that are very simple and straightforward, and you just need to move through these puppies very quickly. Like, we do not have time to waste on this test, because there will be questions like this where you really need to pull out that brain power and analyze it. So, question 6. What is the correct diagnosis for a patient with the following lab results? And I'm not going to read all of this because I don't want to confuse you. I'm going to give you some time, read over those lab results, and then put in the answer that you think is accurate. Okay, hopefully this has been enough time. I know that this tends to be a little bit more difficult. So, what is the correct diagnosis for a patient with the following lab results? We have lots of different answers here. We've got B's, C's, D's. It looks like the B's and the D's are tied. So the very first things that they're going to want to make sure that you understand is, and I put this down here, your little abbreviation, so that just in case you weren't sure, you have your abbreviation. So your HBsAg is your hepatitis B surface antigen. Anti-HBC is the antibody to the hepatitis B core antigen, and you see that little C down here. That's that core antigen. Hopefully you can see where I'm pointing. Spotlight right here, the C. Oh, this is kind of fancy. Okay, and then you've got your next one, which is your immunoglobulin M, IgM, anti-hepatitis B, and it's going to be your core. And then the last one is going to be your antibodies of hepatitis B, surface antigen. Okay, your surface antigen. So you have to remember that when you're dealing with hepatitis, we have different parts of the virus that we're looking at. You've got your core, you've got your envelope, you've got your surface antigen. So there's lots of moving pieces. And this is why I always tell you that you have to review hepatitis and you have to review tuberculosis. They love to have those two diseases specifically on the CIC. They really want to make sure that you understand those two. So the correct answer for this is going to be a chronic infection. And I don't know why it's not lighting up. I thought what's going on? Hello? Oh, there we go, chronic infection. Okay, so here we go. You've got your hepatitis B surface antigen, right, which is positive. All right, so I've got a positive surface antigen. Moving on over. All right, now I've got my total antibody to hepatitis B core antigen. Core antigen. So if somebody has a core antigen that's detected, antibodies to the core antigen, that means that this person has actually encountered the actual virus. Okay, it's not just due to a vaccine, because the vaccine doesn't include that component of the virus. Does that make sense? Is everyone following along? Making sense a little bit with your core and your envelope? Okay, good. I should have put like a virus picture in here so I could explain it. I'm not going to draw it because I cannot draw with this machine, okay? It does not work. I can barely write with it. My writing always looks terrible. Okay, so I've got my core and it's positive, meaning, okay, well, this person had me at some point. But my IgM antibody, hepatitis B core antigen, is negative. So that means, wait a minute, hold on. IgM, right, is the Beyonce of the immunoglobulins. She rings the alarm. She's ready to go. She's telling everybody, hey, we got an intruder. Get it together, immune system, because somebody's going to jail today, okay? That's what IgM does. And so if my IgM is negative, it means this is not acute. This is not acute. She's not acute. She's not here. She's not happening right now. She's not happening right now. And then we got our antibody, hepatitis B surface antigen. That's negative. So that results in us having a chronic infection. This chart right here, super important to understand. Making sure that you go through the hepatitis chapter, watching lectures on hepatitis. It's definitely extremely important that you go over this lab, the lab values for hepatitis specifically, that you understand the envelope, the core, what they mean, the function, like your basic immunology, your different types of immunoglobulins. All of that is very important. Okay, how are we doing on time? We're doing good on time. Okay, a throat culture. This is a quick one, so I'm not going to give you guys very long. All right. A throat culture shows a high concentration of a bacterium, but the patient exhibits no signs or symptoms. This is an example of A, infection, B, contamination, C, colonization, or D, laboratory error. I'm going to give you like 3 more seconds. because this is just a straight up definition. They want to know if you know the definition. Do you know the definition for colonization? Yes or no? And that is a definition. All right. Something's on there, but we have no signs or symptoms. You are colonized. Okay, next one. Question 8. According to OSHA guidelines, how frequently must healthcare providers receive training about the prevention of exposure to bloodborne pathogens? A is going to be every 6 months. B, during outbreaks of bloodborne pathogens. C is going to be annually. D is going to be biannually. And E is with license renewal. With license renewal. They're getting bold with these questions. All right, guys, very good. Everybody was putting in C, that it's annually. Excellent. 10 out of 10. Okay, this is a good one. Question 9. According to CDC guidelines, in the emergency response to a needle stick or a cut, the first action is to A, apply a disinfectant, B, notify a supervisor, C, irrigate the area with normal saline, or D, wash the area with soap and water. What are we going to do first? Okay, very good. So everyone put D. You guys did great. So wash the area with soap and water. So emergency sharps information. Workers, please note, as you work, you may experience a needle stick or sharps injury, an exposure to patient blood or other body fluid. So if any of these occur, take the following step. Wash needle sticks and cuts with soap and water. Flush splashes to the nose, mouth, or skin with water. Irrigate the eyes with clean water, saline, or sterile irrigants. Report the incident to your supervisor and immediately seek medical treatment. Now, I've already told you the story, so I'm not going to tell you again. Just know that I have had to follow these steps. Remember, I told you guys the story of when I was removing the tape with the rusty blade? Yes. So this is important to know. It's very important to know. You got to know your steps. All right, question 10. According to CDC guidelines for caring for Ebola patients, the initial step in doffing personal protective equipment under direct supervision is to A, remove the apron, B, disinfect the outer gloves, C, inspect the PPE, or D, remove the outer gloves. Okay, so this one got a couple of mixed answers, but what I will say is that the majority of the answers are D. Like I would say 90%. I'm not good at math, but it looks like 90% from where I'm sitting. But the actual correct answer is going to be to C, inspect the PPE. Okay, so we're going to go into the steps. It's really important to remember that this specific question is saying under direct supervision, because what that's telling us is that, hey, we've already engaged a trained observer. There's already somebody that's supervising us taking off our personal protective equipment. There's already, somebody that's there making sure we do it right. So we want to inspect the PPE to assess for visible contamination, cuts or tears before starting to remove. If any PPE is visibly contaminated, then clean and disinfect using an EPA registered disinfectant wipe. So that's going to be the first thing that we're going to do. most of you put that we were going to disinfect the outer gloves or remove the outer gloves, and so I definitely understand why you would jump straight to that. But the first thing that they're going to do after making sure someone's observing them take doff their PPE is inspect it to make sure that there's no tears. And then this walks through the whole process of what we would need to do. Okay, question 11. What is the temperature required for flash steam sterilization? A, 100 degrees Celsius, B, 132 degrees Celsius, C, 150 degrees Celsius, or D, 172 degrees Celsius. Okay. Somebody put E, no clue. Okay, good one. So this is another one of those questions that I'm telling you, it's just a black and white question. Do you know it or do you not? If you don't know it, that's okay. Make your educated guess and keep going. Do not allow these questions to trip you up or eat up your time when you are taking your test. I promise you there will be another 5 or 6 questions that you can definitely get correctly if you don't waste your time on these very simple black and white questions. So let's go over flash sterilization. It's going to be 132 degrees Celsius. So flash, and we don't really, so flash is kind of outdated. We really call it IUSS now, immediate use steam sterilization. Like, do people still say flash? Yeah, absolutely. But it's a term that we're trying to kind of move away from, just more like immediate use steam sterilization, which is IUSS. So flash steam sterilization was originally defined by Underwood and Perkins as sterilization of an unwrapped object at 132 degrees Celsius for 3 minutes at 27 to 28 pounds of pressure in a gravity displacement sterilizer. Currently, the time required for flash sterilization depends on the type of sterilizer and the type of item, whether it's porous versus non-porous. Although the wrap method of sterilization is preferred for the reasons listed below, correctly performed flash sterilization is an effective process for the sterilization of critical medical devices. Now, it's very important to this is all going to tie into your cleaning, disinfection, and sterilization chapters, but it's very important to know that we highly discourage immediate use steam sterilization unless absolutely necessary. It has to be absolutely necessary. We don't have that piece of we don't have that instrument anywhere else. We don't, you know, we don't have it available. Immediate use steam sterilization would not be appropriate if, per se, one of your vendors brought in their devices late or brought in the tray that a surgeon needed late. There are very specific processes for vendors dropping off trays. Our sterile processing departments need to have enough time to do what they need to do. So this should not be common practice. You shouldn't just be like, yeah, we're gonna flash sterilize everything, boom, boom, boom. You get flash sterilization and you get flash sterilization. It's something that we highly discourage within infection prevention. But what is the temperature required? Per CDC, 132. But again, caveat, it depends on the type of sterilizer that you have in your facility. So that's something that you can very quickly and easily find out by visiting your ORs and spending some time with your SPD folks. The sterile processing department is one of my favorite departments in the whole building, okay? They're just fabulous down there. They're just amazing. Okay, so question 12. Under the Spalding system, which of the following is classified as a semi-critical item when considering methods for sterilization / disinfection? Okay, you guys did very good. All right, so let's go through these. You guys, most of you have the right answer. Okay, so surgical instruments. What category are these puppies gonna be? Non-critical, semi-critical, or critical? Yeah, critical. What about a prosthetic implant? It's an implant, so what does that mean? It's critical. Okay, and then what about a blood pressure cuff? Yeah, non-critical. Wow, see, that looks like an E, but I was just trying to make it a C. But that's a C, guys, okay? Do not judge me. So our endoscope is gonna be our semi-critical device. Very good. Hopefully this was an easy one. Oh, I need to erase this. All right. Yep, so endoscope is correct. And you all put endoscope. Question 13, a patient complains of urinary frequency and burning, but the urine nitrate dipstick test is negative for infection, suggesting A, no infection is present, B, the dipstick test should be repeated, C, infection from undetected bacteria, or D, a urinalysis should be done. Okay, lots of different answer choices in here. So the correct answer is going to be D, a urinalysis should be done. So let's go over our rationale. The nitrate dipstick test is used to detect the presence of bacteria or purulent material in the urine, and false positives rarely occur. However, false negatives are more common and may result from low dietary intake of nitrates, diuresis, or infections by bacteria that do not produce nitrates, such as Enterococci and Acinetobacter. Therefore, a negative dipstick in the presence of symptoms suggests the need for a urinalysis to confirm the negative finding. Okay, question 14, we are almost done. When preparing workshops on dealing with pandemics, the infection preventionist should coordinate activities with A, the medical staff, B, the CDC, C, local public health department, or D, state Department of Health. Okay, we've got lots of C's, which is excellent. Yes, we want to make sure that we're collaborating with our local public health departments. So let's go over our rationale. While the CDC and the State Department of Health may provide information that is helpful to the infection preventionist when preparing workshops on dealing with pandemics, and the medical staff may have input, the most valuable contribution is likely to come from the local public health department because it will be actively engaged in leading efforts to combat pandemics. The infection preventionists and members of the public health teams should coordinate efforts and consider presenting joint presentations. And this has been very evident with us, for us throughout the COVID-19 pandemic. Our local health departments are some of our very key and instrumental partners into being able to contain infectious diseases. So for example, right now, we're all dealing with monkeypox, right? So we're seeing monkeypox patients coming through our emergency departments. I know some states more than others. Florida's up there. I think we were at like what 500 something cases. New York is up there. California is as well. But the department or the people that I'm most often dealing with is our local health departments. They're the ones who are always helping us with management, containment, education, notices, communication. All of that stuff is going to be your local health department. The state does get involved at times, but it's going to mostly be your local. All right, question 15. After 2 patients developed sepsis and died following cardiac surgery, the initial response should be to A, cancel all surgeries, B, cancel all surgeries by the surgeons involved, C, conduct a root cause analysis, or D, increase antibiotic prophylaxis. Excellent work. Everyone's putting conduct a root cause analysis. Yeah, so we definitely conduct a root cause analysis after we have those sentinel events happen. Let's just be very honest. The first 2 are definitely not going to happen. We won't be canceling all surgeries, and we won't be canceling all surgeries by the surgeons involved. Also, the reason why we need to conduct a root cause analysis before we even determine what the next best steps are going to be is because what if both patients had their appropriate antibiotic prophylaxis done? Then that points towards this isn't this isn't going to be accurate. Okay. So the initial response to sentinel events should be to conduct a root cause analysis. It's important to avoid jumping to conclusion and assuming that the problem lies with the surgical unit or with the surgeons, even that the causes were the same until research is concluded. During root cause analysis, the IP reviews medical records, conducts interviews, and makes observations, tracing all steps during hospitalization and care to determine where the system broke down or the problem arose. Okay, so 16. After completing a root cause analysis to determine the cause of adverse outcomes, but before completing an action plan based on the results, the infection preventionist should A, conduct a review of the literature for best practices, B, survey medical staff about preferences, C, take punitive action against those at fault, or D, ask the administrative staff for advice. This should be a pretty easy one, very quick one. Very good. Very good. Yeah. So we have to make sure that we're conducting a review of the literature to figure out what are our best practices, and not just that, but also, has anyone else ran into this issue? Has somebody else faced this very similar scenario? So for example, let's say you start to notice, I don't know, let's think, your craniotomies all of a sudden, you start to notice lots of serratia or lots of Burkholderia or whatever, let's Pseudomonas, and that wasn't happening before, right? So now your patients are having this pathogen that's coming up with this very specific type of procedure. Is it just one surgeon? Is it multiple surgeons? Has somebody faced this before? Did we change? Was there a product change? Is there a practice change? Is there a new piece of equipment in the room? Like, there are so many different types of things that you have to look at. And then you also have to look at, well, for other places or other organizations that have noticed an increase in their craniotomies, and then all of a sudden they started having serratia infections or Pseudomonas or whatever else it may be, what were some of the things that they believed contributed to that issue or to that problem? It gives you a really good starting point, and you're able to discuss with your clinical teams and your surgeons, hey, this is actually what the literature says. This is what I was able to find. These are some of the things that I believe we need to look at. It's very important. That's a big part of what we're doing in infection prevention. Okay, and our last question for today. In a probable foodborne outbreak, afebrile patients developed severe bloody diarrhea and abdominal cramps in 1 to 10 days, peaking at 3 to 4 days after eating at a county fair. The most likely pathogenic organism is A, E. coli enterotoxigenic, B, E. coli enterohemorrhagic, C, Salmonella non-typhoidal, or D, Staphylococcus aureus. Okay, we've got lots of different answers. We've got some A's, some D's, some B's, lots of stuff, which is good. We've got some diversity. So what this is asking you is basically, hey, are you familiar with your enteric pathogens? Now, oh, sorry, did this one not light up? Oh no, that's so sad. Okay, so this is going to be our rationale. So bloody diarrhea and abdominal cramps without fever, 1 to 10 days, most at 3 to 4 days after exposure. This is our correct answer, E. coli, enterohemorrhagic. All right, so then we've got our E. coli enterotoxigenic, which is diarrhea, abdominal cramps, and nausea with occasional vomiting and fever 6 to 48 hours after exposure. Our salmonella, which is non-typhoidal, which is diarrhea with fever and abdominal cramps 6 to 10 days after exposure, most at 6 to 48 hours. And Staph aureus, which is nausea, vomiting, and diarrhea 1/2 to 8 hours after exposure, most at 2 to 4 hours. So this is going to have your, a very quick onset. So this question is just, hey, do you know your enterics? Just keep in mind that the chapter on diarrheal illnesses it's a very, very long chapter, and there's going to be a lot of different onsets, incubation periods, and I completely understand why some of it may be confusing trying to remember, okay, well, what's the incubation for this? What's the average? How much, what's going to come up frequently? Just try to find ways that you're able to put, certain GI illnesses into buckets and kind of go from there. Which is going to be my very quick onset? Which one's going to take a little bit longer? Try to find ways that can help you remember that. And then for a lot of our EPIs who work in general epi and they've done work with enterics, some of these questions are going to be a little bit easier because they're constantly reviewing, their enterics. All right, guys, so that's it. That's it for today. I'm not going to be doing the week 15 chapter on pregnant healthcare personnel because there's already a very good PowerPoint that's up on YouTube on pregnant healthcare personnel. So you guys please feel free to go on there and watch that one because I just don't really think it's necessary for me to cover it again. So where is it? Right here. All right, so CIC study group, pregnant healthcare personnel. Really great presentation. It's already put together so that way we can try to stay on track. Otherwise, this group is not going to end till like 2025. And we need to end it at some point for this cohort. And I'm hoping it will be in 2022. So that's it for today. Thank you so much for your time. Hope this was helpful. And then we will be starting next week with our next segment, which is going to be management and communication, which will be week 16. Okay, that's it. That's all I have for today. Thank you so much for your time and enjoy your weekend.